Thank you all very much for your time today, and appreciate the host for allowing me to speak and for the chairman for allowing me to be here. Craig McMains from Indianapolis, Indiana. I'm going to talk about pushing the boundaries of lateral surgery. So you might be familiar with the phrase from Isaac Newton about if I have seen further than others is by standing on the shoulders of giants. And that's referencing this Greek mythology, seeing here in this old manuscript of the giant who was blind, Orion, using his servant Sedalion to see further. And if you squint really carefully, you can see that it's actually me standing on the shoulders of Dr. Pimenta looking ahead. So thank you to the giants for allowing me to learn lateral surgery and then to push my boundaries. So the goals today, I'm going to identify some common barriers to adoption of lateral surgery. And then I'm going to outline the current enabling technology that's pushing that field forward. And I'm going to challenge you on what you consider to be enabling technology. It's more than just gizmos. It's concepts and other things. And then we're going to recognize some opportunities for further development in this space. So what are these boundaries? Well, to the giants in the room, the Neil Anons, the Luis Pimentas, Bill Taylors, Tony Kwans, there are none. To the rest of us, there's three things in particular I think that always stand out when I talk to my colleagues. It's the comfort with the surgery. It's the reproducibility of the surgery, and it's the dilemma that we find ourselves facing at 4-to-1, like that concurrent pathology. So about 20 years ago, Dr. Pimenta presented in Brazil on this idea of a lateral transose approach, and then it was published subsequently several years later with Dr. Taylor. And since then, we've seen the number of fusions climbing throughout the country and the world done in the lumbar spine, but lateral fusions have not necessarily followed that same trajectory. And this is not to say that minimally invasive spine surgery hasn't been increasing. We've shown that minimally invasive spine surgery is becoming fairly mainstream, but the rates of lateral surgery being done have not followed the same kind of slope as, say, like minimally invasive TLIF. So when you ask yourselves, like, if 20% of our surgeons are not doing this surgery that we all feel has tremendous benefit over other types of access, what are the barriers? The first barrier I'd like to address is comfort. And I think this is broken down into three subcategories. The comfort that the surgeon has with the anatomy, the comfort that the room has with the setup of the surgery, and then your physical comfort as a surgeon. And when I'm talking about anatomy, I'm not talking about just the plexus. I'm talking about accessing the retroperitoneal space. Remember, this is a potential space. It doesn't exist in its native state. It's like the approach we do to our necks. Right? We have to develop that potential space to get a safe corridor down to the spine. So you have to be comfortable with that anatomy, and that's not something that some surgeons innately come out of training with. Secondly, the room comfort. This is the way I used to do my lateral access, maybe not that much 3M tape. I don't have stock in 3M. But this is not something that the room looks at and it feels inherently comfortable with. If you become a very slick lateral surgeon, the room can set up this patient for you, but when you're first adopting the procedure, this is a challenge, and you have to physically be present in the room at all times as the surgeon to set up the case. Last, the physical comfort. Surgeons, we should think of ourselves as elite athletes. We come out of a long period of training, we have a short playing career, and then we're done. And so we need to maximize the time that we have and preserve ourselves physically while we're in that field. Surgeons have a lot of musculoskeletal disorders, Dr. Skurian, obviously. But a lot of that's actually dependent upon our occupation, and the prevalence is rising. Orthopedic surgeons, we're familiar with this from sports medicine and joints. It's very challenging on our bodies. But even as spine surgeons, we have some of the highest rates of neck issues of any profession in the world. And think about that, because when we're doing these cases, we're looking down on the spine, flexed forward in our necks, wearing headlamps and loops. I have a big head, it's heavy. These things are challenging ergonomically. And if I Google image search lateral access, this is one of the first images that shows up. This is that same posture, right? It's mechanically disadvantageous. So how do we break down that barrier for comfort? Well, let's talk first about the anatomy. Here's a great paper. If you haven't read it, I highly recommend it, out of Japan. And it basically delineates the retroperitoneal anatomy from a lateral access. And the point I want to highlight is that the best area of entry is at that border between the quadratus laborum and the transversalis musculature. You get into that space, it's really one of the most reproducible spaces to access the retroperitoneal anatomy safely. You can then sweep your finger caudally along the inside of the pelvis and develop that plane really efficiently. And you can do that in a lateral decubitus position, right? If you come from a posterior lateral approach, it's there. But sometimes, especially if you're not used to doing these surgeries, palpating that border in a lateral decubitus position can be, not efficient. Here's the first enabling tech I want to talk about, the prone position. So when you're prone, that anatomy swings out to the sides, and that delineation between those two borders, I think, becomes very easy to palpate. And I would recommend that everybody, when they first begin to incorporate lateral access, does a 2-incision approach. We can talk about the cosmetic disadvantage, but from a safety standpoint, this is superior every time. And this is also efficient. I mean, look at this. This is one of my data sheets from my cases from this past Monday. I did a 3-level access, and my times for access from incision to docking my retractor, 4 to 8 minutes. So this is quick. And even if you don't have the comfort to do this in your head and visualize that anatomy, we have some really cool virtual reality tools now. Model your patient-specific anatomy off an MRI and get comfortable knowing where that anatomy is. Train yourself to be comfortable with the anatomy in the retroperitoneal space. Secondly, every OR room is comfortable with a prone positioning and the setup of that. You don't have to be there for the nurses and the techs to get your patient on the table. And then that takes a lot of stress off the room. And then finally, once they're in that prone positioning, the lateral access is you're not floating above the patient looking down. You can sit down. I'm wearing lead. I'm working with my arms down, mechanically out of infusion positions, line of sight. Even if you're swinging something heavy like Thor's hammer here, you can do the case pretty reliably pretty comfortably. Okay? So we talked about the comfort. Let's move on to the reproducibility of the case. Several factors lead to variation in reproducibility. That becomes with the stability of the patient on the field, the body habitus, and the neurovascular anatomy. These are the pain points I commonly am told about. Patient stability. Tape is viscoelastic. It stretches out as we use it. So if we're looking at our patients sitting on this lateral aspect where we don't have a lot of surface area in contact with the bed, and we're taping them down for stability, we've shown in the orthopedic literature for sports medicine that after about 30 minutes, tape flexes out. It doesn't really do much of any good. And that happens if you're doing like a multi-level case. They all shift. Mine used to shift all the time. Instead, position the patient prone. Once again, enabling concept, right? So now let's add some technology on top of that concept, a prone positioner, patient-specific positioner. Because now the patient has more surface area contact with the bed in the prone positioning, and you encapsulate them with lateral bolsters that allow them to be rigid when you're working. So when I'm sitting there mouthing away with Mielnor, I'm not pushing the patient away. They have a barrier against moving back and forth. So if you're doing prone positioning and you're not using a specific positioner, just be very careful. The patient can shift. And then once we have that stability, we can start stacking enabling technology. We can bring in navigation. We can bring in robotics, because those are all dependent on the patient not moving during the surgery for them to be accurate. And so, and if you're one of those people that Dr. Taylor mentioned earlier that, you say, I'm free, I'm so good, I don't need navigation or robotics, my freehand technique is superior. That's not true from a population standpoint. We have paper after paper highlighting that, we get increases in accuracy when we utilize our enabling technology at our disposal. So stack the enabling technology that you have available to you. Finally, habitus. There's no way to really break this barrier. It's going to be there, but this is not an exclusion criteria. Picture's worth 1,000 words. Let me show you a case example. This is a patient I had. When she initially presented to me, she just had some mild radicular pain, and so this was, not a good candidate for elective surgery. I told her to go lose some weight. Well, she was a good patient. She tried to. She fell off the elliptical and then had acute weakness from her, developed unstable spondy. So this is her position on the table, quite a large habitus, a BMI of roughly 50. These are preoperative images showing that mobile spondylolisthesis and acute stenosis. And so how do we enable ourselves for success in a lateral space? Well, I placed the patient prone, and I put her on a positioner designed for prone surgery because then she's stable. I could have done this lateral and the belly would have fallen away, but that soft tissue window is so big it would have caused the patient to move during the case if I was just taping her. I use tape, but it's only just to pull tissue out of the way slightly. Secondly, I used a 2-blade retractor, not a 3-blade retractor. To quote Henry David Thoreau, simplicity, simplicity, simplicity. I want my retractor to go in, to be rigid, and to be focusing on just the area I need to work. I don't need extra access. I don't need extra visualization. Finally, I use my CT navigation. I stacked that enabling technology because the patient, I couldn't do fluoro-based screws on this lady. I couldn't see the pedicles. So I had to utilize my CT-based navigation to place my screws, which almost buried the towers. So in the end, though, by utilizing this enabling technology, I pushed my boundary. And so I would encourage you to do the same. The last barrier in the reproducibility is the neurovascular anatomy. We've talked with Dr. Taylor about the benefits of prone and some of those neuromonitoring advancements. There's also advancements in how we can visualize the psoas anatomy. So if you have the Mickey Mouse psoas, you want to become a lateral surgeon and do every case lateral. This is a challenge, right? This is one of those contraindications for people as they adopt. Well, my previous experience was when I had that very similar picture on a patient, I would do an anterior to psoas. I'm still trying to do lateral surgery, right? And that's an option. You can absolutely do that. You should have more than one tool in your toolbox. But in my hands, this had to be a case I used one of my access surgeons. It was just not as efficient as I would like it to be. Now, when I do these patients in a prone position, I know that psoas is pulling posteriorly from our literature. I can then do this in a direct lateral approach. I can do it without an access surgeon, and I can get a very similar outcome. So just another way that I'm utilizing enabling technologies to make myself more comfortable with my lateral access. Use the 2-bladed system. You can dock anteriorly. You can stay out of the plexus. You can dock posteriorly if you're comfortable with that. You can then dock in the midline, and then kind of like somebody climbing up an ice wall with pickaxes, right? You can kind of shim each blade independently and work your way until you have a working corridor that's feasible. The last way to visualize that neurovascular anatomy is we can use some other technologies. We can utilize ultrasound. We can visualize through the psoas, see where the plexus is directly, and then find a safe trajectory if you're somebody that has to look at where that anatomy is directly, not just rely on the neuromonitoring. We can also utilize augmented reality. That's probably going to be a rapidly developing space here over the next few years. Has a lot of buzz around it, but it has the potential to allow us to visualize in three-dimensional space, maybe in real time, the ability to see our plexus and our psoas anatomy. The last boundary, that 4-5 dilemma, why do we talk about it? Because that's where the money is. That's where 80-90% of all disease is going to show up. And so the solutions that a lot of people have is they do A-lifts, and then they go posterior, and they do lateral. They make this person into a rotisserie, right? And it gets the job done. It's reproducible in a lot of hands, but it's not necessarily efficient. And it's something that I try to avoid if I can. So as I've gone forward, I've learned that the prone positioning allows me simultaneous lateral and prone access and all the alignment benefits that we've already discussed. I can then leverage further enabling technology, modular screws and expandable cages to make my cases more reproducible in that radiographic outcome, and I can use navigation and robotics to place those implants. A couple case examples. I have a 38-year-old male. He's a farmer, heavy guy, corn-fed, as we say in Indiana, and he had a failed lumbar fusion. He had adjacent level disease as well. I ended up doing a 20-degree cage without an ALL release, and I ended up then going in using navigated cortical screws to work around the broken hardware, and then to leave myself room to do a wide osteotomy at 5-1 with bilateral expandables. And I ended up with a great result using my CT navigation, all right, stacking that enabling technology. The last example I have is a multi-level lumbar fusion, and I utilize expandable cages so that I could get that 4-to-1 optimal lordosis around 40 degrees, even though my 5-1 wasn't able to accommodate that. So where do I see going forward from my shoulder here? I see that we can utilize enabling technology built from the ground up, maybe so that we can work in that 180 to 270 degree space using a smaller, more nimble, maybe robotic technology with a wide field camera so that we can see more field. I can use AI constructs and also predictive analytics with our neuromonitoring so that maybe we can plan our approaches the way we plan our constructs. Any questions? Thank you, and go Boilers tonight.
Let's put the next one. Thanks very much. So we're going to try to keep moving. We have Elizabeth Lord in here. Nima, you want to say something? Just say before while we set up Liz in here. You have no voice? You just yell, man.
Yeah, but I don't want to yell so loud.
Such a prima donna.
People virtually can hear it. So a question about ergonomics of prone. I think it's the first time I heard that prone positioning is a better ergonomics than lateral. I mean, I don't know if I'm
I always, that's a good question. I'm gonna get Bruce to do it because I'm doing prones and laterals. Obviously it's a lot of marketing in here, this and there, but I'm not sure which one is better,
I mean, so I sit, all right? I roll the patient slightly, and so I'm looking down about a 10, 15-degree angle, kind of following what our natural line of sight is. I'm totally mechanically advantageous. My arms are down. I'm not having to bring my arms up over the field. I'm not looking down, I'm not flexing my neck. And it's really to make sure that I'm not shredding my rotator cuff. I'm not straining my neck.
But so funny because I would say the anatomical position for carpenters, for surgeons, for everything always is you work in the top of the bench. Like the way that we do post-lumbar, the way that we do cervical, the way that we do ACDFs. That's the natural position of the surgeon. We as a neurosurgeon, when we do brains, when you do the pineal, sitting is tough. Your arms start becoming, obviously they're long surgeries, but I just want to play advocate both sides because to be honest, I don't know what is the perfect position.
No,
I don't
the
think
perfect position
I don't
is
think
the
like you just sitting, the surgery becomes like you can be there. I'm not sure.
The best position always is the one that your muscle are relaxed, right?
Yeah.
Whatever the muscle is. If I'm a short guy.
I'm not sure what
These guys are taller.
What is for
so
you?
if I do this here, and I have a big patient, if I do lateral, I have to stand on some things and plus bend, which is not, for sure, not a good position ergonomic. But if I have the patient in prone,
right,
I raise the table
your
to
head is
my
there.
arms, then I tilt and my arms relax it.
Yeah, exactly.
Cannot be better than that.
Something that doesn't get pointed out a lot is also where the C-arm is. Remember, if you're doing a lateral decubitus case and you're standing posterior to the patient, your C-arm to get that AP view as you're working is kind of right where you want to be standing. And so you're really not only bending over the field, you're cocked off to the side, not like totally behind where your incision is. So in the prone positioning, I can be exactly where I need to be, and the C-arm's out of my way.
So I'm going to ask you a question that Liz just put in here. Just put yourself, all of us with surgeons, put yourself in these three positions, okay? Doing a laminectomy, yeah? Doing an ACDF on the microscope, okay? Or a metric system on the microscope. Doing a prone lateral, you're sitting doing like the prone. Or doing a lateral. Which one you prefer of all that procedure? Which one is the most comfortable for you as a surgeon?
ACDF.
Microscope, yeah? Is that what do you think, Lee? I think the position of the microscope is ideal. Is your anatomical, what is the best position for the eyes? Your line of sight, yeah? You put the microphone right here, and then your hands are rested, and you're working that. That's probably the best position, yeah? You don't get it on the laminectomy. You don't get it also like this, sitting like this, yeah? Interesting, no?
Yeah.
That's a good point. She's a smart girl. That's the next talk. Okay, so she's going to keep going on prone laterals. That's why, guys, let's keep the discussion.